Hello, and welcome to tonight's live webinar. My name is Marie Risky, and this evening is sponsored and hosted by AstraZeneca. We are delighted to have participants from across Australia and New Zealand. Thank you for registering, and welcome once again. This evening, we will hear from two speakers who will be discussing the delivery of telehealth interventions in chronic respiratory disease. They will share their personal experiences, practical strategies, and outline the risks and rewards of telehealth. They will address the clinical, administrative, and technical considerations for this method of healthcare delivery to support you in providing effective virtual consultations. The first speaker, Dr. Barton Jennings, is a respiratory and sleep physician based at Monash Health in Melbourne. Inspired to help as many people as possible maximise their quality of life through achieving healthy lungs and sound sleep, telehealth has allowed him to reach more people and improve the service that he can provide to patients and their families. Barton started telehealth clinics in 2012 after returning to Melbourne from his interventional pulmonology fellowship training at Sir Charles Gardner Hospital in Perth. Since then, he has adjusted and improved the way in which he utilises telehealth. He comments that he has had fun doing this and learnt a lot along the way.
Thank you very much, Marie. Thank you for that introduction. As Marie said, I'm a respiratory and sleep physician based at Monash Health in Melbourne, where most of what I do is lung cancer and bronchoscopy. And the rest of my time I spend in private practice, where I do a combination of general respiratory and sleep. And a part of that has been telehealth. So I've entitled my talk tonight, Consulting from My Bedroom, because the first time I started doing telehealth, I was actually doing it from my bedroom, which I'll show you. And I'm going to talk about a telehealth model of care for respiratory and sleep medicine. So I'm going to start with a quick case study of a patient that I managed with telehealth. I'll talk a little bit about the origins for telehealth from a physician point of view, the software that I use to support remote clinics, a little bit about the secretarial support that can help within telehealth consultations. I'll talk about some hardware that I use that I find helpful, and then also finish with some patient feedback. So just to start with, I just wanted to present a quick case of a 74-year-old man who presented with the incidental finding of a lung mass found on CTPA performed for worsening shortness of breath. He was an ex-smoker, had some previous asbestos exposure and a past history of known severe COPD and sleep apnea. And he was based in Traralgon, which is in Gippsland in Victoria, about 2 hours out of Melbourne. And so this was the CT scan showing a nodule in the right upper lobe, and here we can see that it's in the posterior segment of the right upper lobe with an airway leading to it. So I saw him initially by a video conference and arranged for lung function testing to be done at Maryvale Hospital, which is a local hospital near where he lived, and a PET scan, which was performed at La Trobe Regional Hospital, which is the regional hospital in Gippsland. So his lung function showed that he had quite severe airflow obstruction and a moderately reduced gas transfer, and the PET scan confirmed that the nodule was FDG avid with no evidence of metastatic disease. So I then organised to bring him down to Melbourne, where I performed bronchoscopy, and here's the fluoroscopy picture of the radial EBUS probe going into the lung nodule to allow safe biopsy of that with very minimal chance of pneumothorax in someone with minimal lung reserve. We were able to then discuss his case in our lung multidisciplinary meeting, which I chair at Monash, and here's us doing our meeting at the moment via Zoom during these COVID times, and we were able to review the pathology that showed that the biopsy confirmed squamous cell carcinoma of the lung, which was early stage. So after the multidisciplinary meeting, I was able to review the patient again by video conference, explain to him the diagnosis, what the outcome of the meeting was, and that given that he had poor respiratory reserve, was recommended for radiation therapy, and he underwent stereotactic radiation, which could occur locally close to home. And so one of the difficulties that we're faced with in Australia is with our healthcare system is that we have very large distances separating very small populations. And this is a couple of pictures that I took on my drive home from Perth after I'd finished my fellowship in 2011. And this is reflected by a change in life expectancy based upon where you live. And so you have a greater life expectancy at birth if you're living in a major city compared to a regional area or a remote or very remote area. And so traditionally, to overcome this, we've used services such as the Royal Flying Doctors Service, which was founded in 1928, and where they would fly out to pick up sick patients to take them into the regional centres for medical care. But obviously this is a very expensive service, and so in more recent times with the use of technology, telehealth has emerged as a way that we can deliver healthcare into rural and remote regions. And so telehealth initially started off as medical consultation via video conference. And in July of 2011, Medicare started to try and really promote this to physicians, and they created a new item number, which was the 112. And so the 112 essentially added 50% to the base item number. So if you were seeing someone for the first time, if you were going to bulk bill them, you'd bulk bill them the 110, and the 112 would add 50% of the value. And this was really to encourage people to use telehealth, and also to acknowledge the fact that medical consultation by video conference was often more complicated than the traditional face-to-face consultation. And the overall aim was to increase access and reduce cost of specialist healthcare to patients in rural or remote areas. And so to use the item number 112, you had to have visual and also audio contact. So at that time, you could not bill for phone calls. But there was no restrictions on what technology you used to be able to establish video and audio link. The physician and the patient had to be at least 15 kilometres apart from each other at the time of the consult, and the patient had to be within a geographical eligible telehealth area, which was defined in Australia as being the white bits. And so you can see that patients within metropolitan cities, the capital cities in red, were not eligible for having Medicare rebates for their telehealth consult, but everywhere else they were. And since then, there's been a lot published, and there's multiple international journals, as well as Australian conferences and journals, all based around telehealth and healthcare via video conference. And interestingly, the Australian Telehealth Conference was once again due to be in Melbourne this year, but it was in April, so unfortunately it was cancelled due to COVID and changed to an online conference, which is maybe quite appropriate. And the College of Physicians also has guidelines with regards to practical tips for telehealth. So when I got back from my fellowship in Perth, I decided that, having enjoyed my country rotations during my training and wanted to continue to work in the country, that I would set up a country-based service and utilise telehealth. And so I started doing face-to-face consulting in Maryvale Private Hospital, which is a small private hospital about an hour and 45 minutes out of Melbourne in Gippsland. And I would go there once every 4 weeks for a full day of consulting. And then every other week, I did a half a day telehealth clinic. And so the way I set up my telehealth model at that time was that I had a dedicated video conference clinic room. This was based in Traralgon, nearby Maryvale Hospital. And so there was a secretary there to meet and greet the patients. And so it ran like a clinic, and the patient would wait in the waiting room until being brought into the consulting room. The secretary also provided the ability to send email to the secretary with requests and scripts and information sheets that could then be printed out and given to the patient. The patient was charged a small fee by the clinic for the use of the telehealth room, and I bulk billed the patients using the item number 112. And for some patients who lived a long distance away from this clinic, Gippsland's a huge area in Victoria, I did allow the patient to go and visit their GP, and I would set up a video conference link with myself and the GP and the patient, or sometimes a practice nurse. And I gave a talk about telehealth in 2016 to a group organised by the College of Physicians, because at that time I was one of the higher users of telehealth for physicians in Victoria. And so this is how it all started. This is me in my bedroom with my little desk and iPad set up there for the video conference, and I could quite comfortably on a hot day sit there in my shorts and no one would know. You can also have a glass of wine at the end of your day. I've put that there purely for this photo, just for comic effect though. And this was the other end on the patient end. So I just had a laptop set up with some speakers and in a consulting room. And so the patient was able to see me via video conference. And apart from the fact that I wasn't there in person, everything else ran exactly the same as a normal clinic. And I always avoided the idea of actually having the patient at home during the video conference, because I thought that if the patient was going to be at home, I would have to put up with their internet, I would have to put up with their distractions, and sometimes patients might not take it seriously and not see it as a real doctor's appointment. However, then along came COVID, and apart from all of the bad things that have occurred to our life and the difficulties that it's thrown up to us, it certainly brought about some significant opportunities, and some opportunities where we can do things differently and opportunities where we can improve the service that we deliver to our patients. And so very quickly, as I'm sure everybody has experienced, we've had to go to a telehealth model to avoid having patients coming into the hospitals and into our clinic rooms. And so we decided to Zoom telehealth into the patient's home at that time. And so although telehealth via video conference was certainly our preference as to how we wanted to conduct our telehealth, we did also allow telephone for patients that did not have access to video conference or computers or internet, or who were not able to use that technology. This transition was difficult, but it was made easy because the practice was quite well set up with some cloud-based software that was able to support remote clinics. And just to go through a few of those, because I think that they're really useful. We run our practice management on Clinic to Cloud, and we changed across about a year and a half ago from Genie. And this has been a fantastic move. And if anybody's thinking about new practice management software or going cloud-based, I highly recommend Clinic to Cloud, and be happy to talk highly to anyone about it who is interested. We use G Suite for all our email, cloud storage, and for our documents. We use Dialpad for our phone system. So Dialpad's a cloud-based phone system where we have 3 separate lines, and I can answer my clinic phone if I wanted to from any computer in the world, so long as it has internet. And so that's really helpful for having remote clinics, and also for having secretarial support working in remote locations. iLung iSleep is our practice intranet, which I've created. And so our practice intranet basically has all of our systems as to how to do everything within our practice. And I built this on Google Sites. We use Asana for task management. Task management is really important when you have a few different secretaries, especially if they're in different locations, so that everyone knows exactly what tasks need to be done. Tasks can be assigned to certain people and given a date that they need to be done by. And so it really helps organize workflow. I use Delonix for remote secretarial support, and we have an office in the Philippines where I have a secretary based. We use Google Chat to communicate during the day, which is much more efficient with instant message rather than email back and forwards, which can be inefficient. And we use Tyro for our billing, which allows an online virtual terminal, which is really useful, especially for billing when the patient's not in your rooms in front of you. And we use the normal radiological and pathology platforms that allow online viewing of images and pathology. And so this is iLung iSleep based on our Google Sites. And so all of our secretarial systems are located in one place. And here's the system that I built very quickly after we had to change our telehealth model so that we could have remote clinics and appointments. And so we go through an overview of the system, explains exactly how that my secretarial staff need to book appointments, how to explain to patients with a video that goes through it all, and then a quick summary of the steps to refer back to. So this is Asana, and Asana is for our task management. So we have our daily, weekly, and monthly recurring tasks, all assigned to certain people. And we can also put on one-off tasks, and it works really nicely because if you put on, rather than sending an email, where sometimes if you get a whole lot of emails throughout the day, your task might be lost within that email. It works a little bit better, and when a task is complete, it's ticked off, and I get a notification on my phone to say the task is complete, which is really nice to see, rather than getting email responses. But for telehealth, we decided to use Zoom. And Zoom works really well for video conference. I'm sure everybody's used Zoom. We use a Zoom Pro account, which costs us $21 a month. And the benefit of that is it allows an unlimited time for meetings for 3 or more participants, where the free version allows unlimited time for 2 participants only. But as soon as you have 3 participants, there's a 40-minute limit. And the importance of that is that we create one meeting for the whole clinic. Once I get into the meeting, I create a breakout room that I call the secretarial virtual office, and Zoom has a waiting room built into it. So when the patient comes into the Zoom meeting, they automatically go into the waiting room until I bring them into the consulting room. I use the share screen feature, which is really useful for showing patients their imaging, CT scans, sleep studies, or anything else that you want to show on your screen. And I think patients really like to be able to do that, similar to what you would do in a face-to-face consult. And we also allow family members to join the meeting. And a family member could join the meeting from an alternate location. So for instance, if a patient is in their home, they possibly have their daughter or son join the video conference, and they could be at their home or they could be at work. And you could have a three-way meeting to allow a family member to join in on the consult, which is really valuable. And then I use an email that I send out to patients with instructions as to their appointment and how to set it up. And so this is Clinic to Cloud, and so we have our patients booked in like that, and on Clinic to Cloud we identify whether they're a patient to be seen over Zoom, phone call, or in person. And at the top of the clinic, I just paste the Zoom meeting details, because those Zoom meeting details will be sent out to any patient that's booked onto that list. So this is the pre-formatted or email that I created that starts off as an introduction, and I did a video of myself introducing myself to the patient and explaining telehealth and the need for telehealth, and then a step-by-step instructions as to how to use Zoom and how to set it up. And I've also done a video of me taking a patient through how to set up Zoom, so it really makes it really easy for them, especially some who are not so good with the technology. And so this is how our Zoom meeting works. So there's me sitting where I am now in my home-based consulting room, and you can see the secretarial virtual office is set up where Jelani is, and in the waiting room is the first patient, Leah. And so when I'm ready, I click on the admit button and I bring Leah into the consult. And so Leah and I, who happens to actually be my wife for this photo, actually happens to be my wife all the time, not just for this photo, but this photo was taken with the help of my wife. But so Leah and I finish our consult, and once we finish, I explain to Leah that, say, I want to organise an appointment for 3 months with the lung function test. I explain that I'm going to now bring Jelani, my secretary, into our meeting and introduce you, and she can organise that test for us. So I introduce Jelani to Leah, and then explain to Leah that I'm going to now transfer Leah across into Jelani's virtual office, and they can organise the appointments and follow up. And so I send Leah and Jelani off into the secretarial virtual office, where I can continue to dictate my letter, sort out anything that I need to sort out, wait for the next patient to arrive, and Jelani can go through with Leah, booking appointments, organising investigations, processing billing for the consult, and then Leah can disconnect. And so what we do is we really try to create an atmosphere that runs exactly the same as a normal clinic appointment if face-to-face, except it's all run via video conference. I then send an email to patients if I want to send a script or a request form or information sheets, and we created an email address through Gmail, which is just a free Gmail address with a no reply, so we don't need to use our personal email to send information to patients. With regards to our hardware setup, the most important thing here is that it's useful to have a couple of screens, but the most important thing is that the laptop is propped up on a laptop stand and on a big thick book called Harrison's, which I very rarely look at anymore. So it's put to good use there. But the important thing is that the camera is at eye level. And it's important to have good position on the camera. So you want to look like you're talking to the patient. And so this is the photographic rule of thirds, where your head should be in the top 2/3 in the middle of the video conference screen. This is no good. You do not want to look away from the light because it casts a shadow over your face. So make sure that you're looking into the windows. This is the head in the middle view that a lot of people have that doesn't look so good. This is the look away, and it's okay to look at your other screen, but it's just useful to explain to the patient that you're looking at you've got another computer there or another screen, and you're just reviewing results or looking at the notes. This is a common one, the laptop view. Everyone knows that when you're talking to someone on a video conference, when they're on the laptop and the laptop's sitting on the desk and it's looking up at you. One worse than the laptop view is the up the nostrils view, and that's when you can see the roof. You should never see the roof in the back of somebody's video conference or your own. And this is the close talker. And so when somebody's typing on the laptop, and you don't want to be typing on your laptop when the patient's looking straight at your head. So the other very important thing is obviously does this work for the patients? And so I conducted a 2-minute survey of all patients who had had a telehealth appointment through our private rooms between March 18, when COVID started, and just recently. And so I sent out 282 emails and 64 text messages with a 2-minute survey, and got 120 responses, which represented a 35% response rate. Patients lived in both metropolitan Melbourne and also regional Victoria at about 50-50, and most appointments were conducted via Zoom. and the other lot of them were conducted via telephone, and just a handful via FaceTime as an alternate way to video conference. We asked how the process with regards to setting up the teleconference went, and most people found this very easy or easy. And interestingly, when we broke that up into those patients that had a consult via Zoom, much more of them found it very easy. And interestingly, none of the people who had a Zoom consult found it very difficult or difficult. So it was those that had telephone that found it more difficult. I asked whether the patients would prefer to visit the doctor's rooms to see them face-to-face or via telehealth. And interestingly, the majority had no preference. Some preferred to visit the doctor's rooms, but 30% actually preferred telehealth. But interestingly, if I broke those up to those patients that had a telephone consult to those that had a Zoom consult, those that had a phone consult were much more likely to want to visit the patient's rooms, but those that had a Zoom consult were more likely to have no preference or prefer telehealth. And do you think that the medical care given to you via telehealth will be different to the care received in person? And the majority said about the same, maybe slightly less than about the same. And overall, were you satisfied with your telehealth appointment? And most patients were satisfied. And whether patients would accept further appointments by telehealth, and most patients were very likely or likely to. And once again, if we break that up into those that had phone consults or Zoom consults, the patients who had Zoom consults were more likely to be very likely or likely to want follow-up appointments with telehealth. I asked them if they had any suggestions on how medical consultation with telehealth could be improved, and I got 30 responses. Most of them were positive, and a few things that came through in a few responses was that people thought that maybe an in-person consult was good for an initial consult, and patients also like to see their results of scans and sleep studies. And interestingly, a few people had that same comment, but they were all patients who had had telephone consults, and none of them had had Zoom consults where that's absolutely possible. So based on that, what will we do to change our current model of telehealth? And we will offer telehealth appointments to both Melbourne and country patients going forwards. We will Zoom into the patient's home or work. We'll utilise dedicated telehealth clinic in Traralgon as well, so patients can come into a clinic for those that don't want to use the technology at home. And we will really try and encourage initial review in person, especially for complex respiratory cases. And I think that a telehealth model, especially for a regional or remote telehealth model, is always going to work best if you actually do visit the area as well as provide that telehealth service, and they go hand in hand. And I think that we will discourage phone consults unless there's absolutely no other option. So in summary, I think that telehealth is an excellent addition to respiratory and sleep practice. I think that it's important to ensure that you utilise the great technology available, especially cloud-based technology, to facilitate your remote clinics. Opens the possibility of having remote secretarial office and support, helps with practice organisation. I think video conference is absolutely preferred over telephone. And patients also do like the face-to-face as well. So I think that this is a good addition to any telehealth model, especially for those patients who are having initial consults or more complicated consults. And so hopefully you've found that useful. Please, as Marie said, continue to drop your questions in that we will be able to answer at the end of this. And I'd be happy for people to get in contact with me by email. And you can also check me out on YouTube if you like. I've had over 10,000 views on my YouTube channel, so I've got some interesting videos with regards to respiratory and sleep medicine. And with that, I'll pass over to Greg.
Well, thank you very much, Barton. I mean, what an act to follow. I now understand why I'm speaking tonight, because I'm more or less the opposite of Barton. You can look at the two of us. He's got the headset. I don't. I'm probably doing the laptop view. I was pleased to see that you're not in your bedroom, and I'm not going to ask you if you're wearing shorts tonight, but thank you so much. And look, I represent probably many people out there who weren't doing telehealth all these years that had to suddenly embrace it because of the pandemic and work out how to do it and how to do it in a good and safe way. So I'm going to go through my situation first. So I've been busy doing 100% face-to-face consults for the last 20 years or so. A busy appointment book, a large number, probably several hundred severe asthma patients under my care. 60 of those are currently on biological agents. many of my patients are elderly and COVID at risk. So when the pandemic progressed earlier this year and, everything changed suddenly, in literally one day, the decision was taken to switch this chocker's appointment book to a telehealth clinic. And there was no public holiday or week off to prepare. It was literally done in one day, quite the opposite to Button. So a bit of chaos for us and a lot of learning. We were forced to look at a COVID-19 safe alternative, but the real question we faced was how to do it successfully, and how to do it safely in terms of COVID, but also in terms of patient care. So we actually went into lockdown as a clinic earlier than probably many of the colleagues in the area because of the large number of severe asthma patients and severe COPD patients under our care. And today I'm going to cover a little bit about the journey we took to how we started and how we finished, the lessons we learned and the good things we learned as well as the not so good. So we converted to a 100% telehealth clinic in the space of several days. And that consisted of either phone or video. As we know, Medicare preferred the video, but where video wasn't available or possible, phone consultation was used. In the beginning, I had honestly considered telehealth for quite a few months before the pandemic hit, but never got to use it. So all of a sudden I needed to know more. So as we know, back in March, there were a lot of webinars on about COVID and other topics, and then there were telehealth ones. So every single one that entered my inbox, I had signed up for. And then I discovered there were a multitude of sources out there that Barton again mentioned, and RACP and the other colleges, the ACRRM, the Australian Telehealth Society. So many resources that are out there to make us familiar with telehealth. Medicare itself has online guides about how to do telehealth. I remember ringing Medicare once, getting one story, ringing again and getting a different explanation of the item numbers. And finally, I had to write in and get it back in writing to clarify how the 112 is to be used properly. Is it the patient's address or their location at the time of consult? Turns out it's their location at the time of consult. So documentation is key when you're doing telehealth, to document where the patient is at the time of the consultation and where you are. I spoke to colleagues who were already using telehealth. I didn't know Barton at the time. I would have definitely rung him if I knew him then. And of course, from my own experience, as little as it is and as humble as it is in comparison to the previous talk, my own experience, the troubleshooting that went with it, the learning to be more flexible and to plan ahead and to review is the biggest lessons I learned from doing telehealth. And yet, there have been discussions about providing medical care in this kind of way for almost 100 years. In the 1920s, there was a lot of talk about using radio to provide medical care. And then I just discovered recently that when I was a child chomping on chips in the lounge room after school, there was another source where I was being taught about telehealth without even realizing. So if we can please play this little 1-minute video clip, and some of you may remember these moments.
I'm coming down with Venus virus. Venus virus, eh? Last week you said it was Martian bumps. Anything to miss the space calculus test. I tell you, I'm sick. Oh, this is it. It's growing black. Quick, where's a pencil? I gotta make up my will. All right, hold on. Just hold on. I'll call the doctor. Calling Dr. Racy. Dr. Ken Racy.
Yes, Mrs. Jetson. Somebody got a pain in the tummy-tum-tum.
It's Elroy, Doctor. I think it's the Venus virus this time.
Venus virus? Oh, that can be catching. All righty, Elroy. This is your dedicated physician speaking. Stick out your tongue. Uh-huh. Oh, my.
Well, what do you see, Doctor?
2 dozen gumdrops, a pastrami sandwich, half a pizza.
Elroy, for breakfast? Well, you see, I thought it was my last day on Earth.
Yes. Well, it pains me to tell you, but there's only one known cure.
What's that?
A full day at school. You're fine.
Oh, boy. Elroy, Thank you, Dr. Gracie. Sorry to call you needlessly.
Think nothing of it, madam. It's my duty as the nation's #1 dedicated physician. Which reminds me, one house call, the usual fee. Don't hurry on bill. Tomorrow morning will be fine. Happy medicine.
Well, Elroy, you just bent your father's rate.
There we are. So don't claim to be the #1 physician, but there are a number of lessons that I believe we can learn from the Jetsons, believe it or not. First of all, the telehealth consult was initiated by the patient, well, the patient's carer in this case, the mother. It's not as easy as clicking on a button and we appear like a genie, but there needs to be a way of booking a consult, whether it's through a phone call or a website if you have more sophisticated software that allows the patient to book online for an appointment. There needs to be a facilitator on the patient's side. So with Barton here has the remote clinic where they can facilitate the video consult. With us, we don't have that luxury or that all those facilities. So we did the calling to the patient's home. So we had to help the patient or the facilitator on the patient's side to set up the video consult, for example. So there was that learning to, teaching my staff how to do it, setting up the introductory email that could be sent through. We can see that the doctor, in this case, did the history examination, a basic examination, came with a diagnosis and prescribed treatment, go back to school. And, comically, he presented the bill. So there are billing issues that relate and are important for sustainability. But also, if you look at the Jetsons, there's, the robots, remote monitoring for temperature, and it seems a bit incredible and unbelievable, but yet these things currently do exist and are being developed. So there are now, there is technology out there where we can take observations remotely. When you look at the Department of Health's definition of telehealth, it's a bit of a long-winded one, but it's defined as the use of telecommunication techniques for the purpose of providing telemedicine, medical education, and health education over a distance. So telehealth is not just about the patient care. It's also about medical education, health education. So those of us who are teaching medical students via Teams or whatever we're using are actually delivering telehealth. Whereas telemedicine is defined as the use of advanced telecommunication technologies to exchange health information and provide health care across not only geographic barriers, but time, social, and cultural barriers. So we have a number of barriers in the way to delivering telehealth. And it's not just, the remote patient, but there may be cultural and other social impediments. So today we've been speaking more about live video conferencing, which is what Barton mentioned, using Zoom or another video-based technology. But there are other forms of telehealth, store and forward, where a patient can collect certain bits of data, whether it's the peak flows or their blood sugars or some other measurements, and they get forwarded to you. The remote patient monitoring, and mobile health, where they may have an app on their phone and data is collected, which you can access. So all these aspects constitute telehealth. So going back to the pandemic, as we all know, there were a number of changes that happened. Initially, what I call the traditional telehealth, with the 112, we had the addition of the COVID item numbers, which allowed for the treatment of not only the remote patients, but the non-remote RA1 area patients in the metropolitan areas. So initially we were told we had to bulk bill all the COVID item numbers, which I have to admit in the beginning was a real struggle for when you're in a private clinic and having to bulk bill every single consult in terms of sustainability. And something about telehealth is that it has to be sustainable if you're going to keep doing it. Traditional telehealth, as I call it, was still allowed. So I've had the pleasure and the interesting experience of doing the COVID telehealth, of course, but actually telehealth for some remote areas and learning to use the 112 and that aspect. It's been a really good experience. The issue was that the Medicare rules kept changing. So every 2 weeks, there was an additional item numbers. The long item numbers got added, the 132 and 133 equivalents. Then we were allowed to charge rebates. So we had to keep on top of all these changes and then be relaying it back to patients. One thing we realized that if you weren't bulk billing and you charged a fee, even though if it was lower than your normal fee, but you told the patient there was no rebate, many patients didn't want it. Okay, the concept of getting a rebate back from Medicare seems engrounded in our mentality in Australia. There were huge challenges in shifting a booked out existing appointment book all to telehealth. And one thing we learned very, very early was that it's not for everybody. Not everybody wants it. And we saw it in Barton's data. There were about, I think, 30% of people that preferred the face-to-face. And that's perfectly fine. We can't force patients to use face-to-face telehealth. Who are the sort of patients likely to benefit from telehealth? Well, those who cannot obviously access specialist service because they're elderly, frail, they may be remote. Those who can't get to a service in a timely fashion. Those who, it's just hugely inconvenient to get in. They have other, so there's the convenience factor. And those who a physical examination is not required. And don't forget the cultural aspects. There may be some cultural factors where they prefer a face-to-face consult and they actually look down on the concept of a teleconsult. So let's quickly go to my patient EB. She's a long-term patient of mine with severe asthma. She's 85. I used to see her several times a year, and her lovely 90-year-old husband used to drive her in, and then they'd take forever to get in the front door and park at the front, and we'd have to help them in and help them out. She'd come in with a rollator frame in the end, and, I kept saying, you don't have to come in, but she wanted to come back. And then the pandemic hit, and she was actually placed in an aged care facility. And the opportunity came and thought, you can actually claim for use of in an aged care facility. So we actually set up a Zoom consult with the nurse in the aged care facility, who then carted the little computer to the patient's room. And I had Ken, her husband, waving in the background. I had a good chat with the patient. The nurse joined in, and it was a really good way to get observations done, to check what medications, what doses she was on of her various inhalers, prednisone doses, to make medication changes, to talk to the patient and to the nurse at the same time. So in the end, I had struggled to get her off the screen. She enjoyed it so much. And at the same time, I felt it was safer for her because of her comorbidities to manage her in this way. And then there were the litany of challenges. As I mentioned, there was no time to prepare for this switch. Not everybody wanted telehealth. So those who were standard follow-ups, who were well, were just simply put off by a few months. The question was, would you offer a phone or video consult? So we tried to offer video consults to everybody. Not everybody could do it, and they, as a default, went to a phone consult. So there's issues around what sort of patient is suited to a phone, especially for a new patient. And I know we're discussing chronic respiratory care today. It's better to see the patient than just talk to the patient. But there are situations where it's not possible. Which video platform to use, which is easy to use, which was secure. We had all this bad publicity about Zoom in the beginning, and I sort of used to laugh in the background because so many of the societies we're part of run the meetings on Zoom. And we developed our own strategy of security. So I don't have the complex room structure of Barton because I just never knew that existed. What we did, we didn't even send out a meeting ID. The most secure way for us, because we were concerned about security and privacy, was I actually gave the meeting ID and password to the patient through the secretary at the time they rang for the consult. So they logged into my phone directly. So there was no sending out of any ID or passwords. So we thought that was quite secure. But it's really important to have a plan B and plan C, because there were times when we tried to get Zoom to work and it didn't. The audio worked, the picture worked and the audio didn't work. And we discovered that was because patients were talking on their mobile to you while they're trying to use Zoom on the same phone. It took about a month to work out that. So there are times where, you end up ringing the patient while you're talking to them on the video. Or what we did was we then got another software, which was web-based, and it doesn't involve downloading anything at all. So I'll go through that in a moment. And that made it really easy to say, do you want the web-based program or do you want Zoom? And if one didn't work, we'd switch to the other in a hurry. And I've timed it. It literally takes less than a minute for them to connect to the web-based platform when the other one doesn't work. Even patients that swore that they can't use technology, we managed to get on within 60 seconds onto a camera. So it's been impressive. I've already mentioned the billing issues around, you know, the changing rebates, COVID versus non-COVID Medicare items. And we really realized we needed to rethink the whole workflow thing again. Is, you know, the patients are no longer coming in, but you still need their referrals, you need their patient information, you need their consent. To bill a Medicare item, you need their consent, and traditionally you need their written consent, but for COVID it was allowed to get verbal consent. So even if I was bulk billing someone, I made the secretary check to get verbal consent from the patient that they agreed to be bulk billed, and we documented that in the appointment book, just to comply with the Medicare rules. There's the question of getting lung function. I mean, I do a lot of airways disease, and how am I going to get spirometry done remotely? I'm not that set up yet. One day, maybe. But I made use of local labs that were open and referred patients for lung function and reviewed them after, either by phone or video, about the results. I'm one of the few that I really do favour peak flows in my asthmatics. I give them a go of peak flows, and it proved really, really useful during the pandemic because these patients were able to tell me how their peak flows were going, and I got some vague sense, at least, that things were stable as well as their symptoms. I had an idea about their peak flows. There was a great fear of technology, not only in my staff, but the doctor, me, and the patient. So we were all managing our anxiety and trying to look like we're in control the whole time. And the workload on the poor staff was really huge. I don't have multiple secretaries, and I take my hat off to what they did. That we had meetings, we reviewed things, we tried to listen to their concerns about where things were hard and tried to make changes. So we really were working hard to make it work. In terms of the video platforms, we use Zoom and CoView. And what I like about CoView is when the patient signs on, there's a consent form, which they accept that, you know, it may not be as good as a face-to-face consult, and a face-to-face consult may be required. They snap a photo of themselves, type their name in, and they go into the waiting room where some nice music is playing. So I chose country for them. When all else fails, we did revert back to the phone, sometimes for follow-ups where the patient really wanted it. We too have radiology, online access, results, download access. I've had online access now to my lung function results because you really need to get the results up front. You know, that sleep study, that CT scan, the lung function before the consult happens. And in future, there will be e-scripts in My Health Record, which, if it can be integrated into what you're doing, will make life a lot easier. And just to move along, you need to rethink the whole workflow issue. What to do before the appointment, you know, get the referrals up front, get the patient information, screen the referrals. Are they appropriate? Do they need to come in for a face-to-face consult? Working out what platform you're going to use, get consent, have results ready, as I said. Just before the appointment, we actually contacted the patient to ensure they were ready, and we facilitated their login, so we're not so advanced. During the consult, there are visual issues, and I think Barton covered that about camera placement, establishing a plan, documenting, making sure the patient understands your instructions, making them repeat them out to you. After the appointment, we would send scripts, and if it was urgent, we'd send it straight to the pharmacy of their choice and then post them the original, send request forms, letters and receipts, etc. So there is a whole new workflow. Just very quickly, the do's. I've already mentioned consent. We need consent for billing, documented. Document everything. Document that it was a telehealth phone consultation done with the patient's consent during the COVID pandemic, performed at 3 p.m. It needs to be done for Medicare purposes. We mentioned the preparation required, having a plan B and C. Evaluation, I know Barton touched on that. It's good to hear what your patients thought about the whole experience and how we can improve things. And one day I did do a video consult with a new patient, and I was told just before I logged in that the GP was present as well, which, you know, I'd actually never done a consult with a GP present before, and it was the most amazing experience. The GP loved it. She got to express her concerns, and it was just a wonderful three-way conversation, and it was extremely positive. Importantly, check address details before posting. You know, the scripts could end up in the wrong address, and that has happened where the receptionist has accidentally typed in the wrong number for the address. So whenever I printed out a script and said, we'll post you the script, double check the address. I managed to do a few little courses here and there about presenting, and this is Tracy Spicer, the veteran newsreader, and this is her trying to teach me to do the newsreader smile. Haven't mastered it yet, but apparently a little smile at the end goes a long way, and it's a good way to close your consult. A few don'ts. We can't force a patient to use telehealth, so where they don't want it, we don't offer it. And we mentioned camera placement before with button. This is me staring at the patient on the screen. Okay, the eye contact is not there. So it's the same for a face-to-face consult. You want to be looking at them. You can't always do it if you're looking at, your computer, but looking at the lens, you have greater eye contact. Like with a face-to-face consult, we have responsibilities. We've got a duty of care to provide, reasonable skill and care when providing the health services to the patient. We have to manage the risks associated with patient privacy. So you don't want to be talking about some confidential issue with others in the room. So you really need to check, are they happy to discuss who's around, things like that. So, and also on your side, there's no one else around or there's, within hearing distance. Consent to consult, billing we mentioned, and document. Generate letters like we always do. I really believe there is a future in this for those who are interested in providing care to chronic respiratory patients. I've mentioned My Health Record already and eScript, so speak to your own software provider. They are currently integrating with these platforms. We'll be able to SMS or email a QR code with a script to a patient in the future. And it's really for those who will prefer it, who will choose it, where it's clinically appropriate and of interest to the patient. And it just provides another option for patient care in the future. So in 100 years, we've come a long way from talking about radio to literally pressing the button and talking to the doctor face-to-face. So finally, I'd like to close off by saying thank you. I actually want to acknowledge my staff who've really worked so hard at trying to make this work in 3 months. And, we still have a lot to learn, but I think it would be great to learn from other people's experiences as well. So thank you for your time.
Can I remind everyone who has a question to in the chat section below? I have a couple of questions here for you. Does a patient's preference for Zoom, phone, in-person consults correlate with a patient's age and their ability to manage the technology?
That's a good question. I will try and answer that because I did the survey of my patients. I didn't actually ask patients' age, so I can't separate that survey data into patients' age, but it would be actually very interesting to find that out. But anecdotally, I actually found, like Greg said as well, that some of I'm always surprised by how older patients often have email addresses, usually always have iPhones or an iPad. They're often reading the newspaper on the iPad. And I think that the older people are much more technologically savvy than we give them credit for sometimes. I also do a lot of bronchoscopy, and when I do a bronchoscopy for a patient, sometimes I haven't seen them beforehand because they've been referred by another respiratory physician, and often it's urgent for lung cancer. And so I actually created a video of myself explaining bronchoscopy and introducing myself, and I send it to the patients beforehand. And it's amazing how many patients, sometimes even in their 90s, will get that email and watch the video and enjoy it. So I think that obviously the younger people are more technologically clued in, but I think the older generation is certainly clued in as well. And the other thing I always do is encourage patients to ask family for help if they're not sure how to do it. And often there's a son or a daughter who's able to help set up the video conference.
Yeah, I just want to echo that. I can only speak anecdotally as well, but I don't think age is really a factor. Yeah, it happens naturally. A lot of the older people say, oh, no, I can't use that stuff. But, if they have a family member who's happy to facilitate, a son or daughter or somebody, or you just tell them, okay, you don't know how to use Zoom, but we have a software that it's literally a click. You don't have to download anything. It is easier. Just the fact that a receptionist says it's actually pretty easy, even I can do it. They've given it a go, and we've offered them a phone consult if it fails. The vast majority of times, those people were able to do it. So you can actually send them an email in advance where they can practice the login. And if it all fails, you've got the phone. But the vast majority get at work. It's all just giving it a go, learning something new. Many of them have used, because of the pandemic, they've used Skype or whatever to chat with families. So it's not completely unfamiliar now.
Another question, what would you as a clinician see as the limitations of consulting via telehealth as opposed to traditional face-to-face?
Go, Greg, or...
I'll go. So the limitations, well, there's always the issue with the initial consultation. It's the first time you're meeting somebody. There'd be huge issues around doing a phone consult with somebody you can't even see. So I think we want to do a video consultation. It's not ideal, and it's probably because of the pandemic we've been forced to do it. The limitation is you can't examine the patient. So if you've got the GP present during the consult in that situation, or a nurse who could examine the chest, that is a help. But yeah, it's where you want to do the examination itself. There is a limitation. I think but it's a useful screening tool where you get the feel that I really need to see this person, or they really look sick. It can be used as a screening tool to say you need a face-to-face consult. And it's part of that disclaimer when they sign into the CoView software that they may be asked to come for a face-to-face consult.
I mean, I absolutely agree. And when I first started doing my telehealth clinic, my idea was that I would see all patients for their initial consult in person, and I would only use telehealth as follow-up. But the way things sort of just molded and merged over the years was that I ended up doing quite a lot of new patients by telehealth. And exactly as Greg just said, if you see a patient by telehealth and you realise that this is complicated, I really need to see this person in as a face-to-face consult to examine them properly, then you can just schedule that. And that's where I think the benefit of having the clinic set up in a way that you also provide a face-to-face consult is really valuable.
Post-COVID, can you see Medicare allowing for mixed billing with new billing numbers such as like face-to-face, teleconference, phone calls for both metro and regional patients? This perhaps the new world, or perhaps for private practice?
Well, I think prior to COVID, there has been discussion about Medicare possibly scrapping the 112 telehealth item number. So I think prior to COVID, that was on the agenda, and I'm not sure whether that was going to happen, because a lot of people who do a lot of telehealth came back and said, well, if you're going to do that, that's going to make it so difficult for us, so we'll just stop doing telehealth because it's much easier to see patients face-to-face. I've heard mixed things, like nothing from any sort of source that would be reliable except chatting, that some people think Medicare will continue this, some people think they will discontinue it. I suspect that a sensible thing to do would be to discontinue phone consults, because I think that it is safe to come to the doctor's rooms now, and I think that the alternative to a phone consult should be an in-person consult, but I think that video conference should be allowed. And prior to COVID, I had actually considered doing video conference consultations to patients within the metropolitan area who, even though that would mean that they would not get a Medicare rebate. And I thought that would be valuable for, say, a patient who was working full-time and wanted to get the results of their sleep study or their follow-up CT scan. Instead of taking half a day off work and coming into the clinic, they could actually do a consult by video conference, and they might be happy to forego their rebate for the convenience and the not have to take the time off work. And the other situation where that would be fantastic would be for the patient who had to come in for a consult, but their son or daughter had to take half a day off work to be able to take their parent to the consult. And so to be able to do a 3-way Zoom consult in that situation would be really valuable, and some people might actually forego the rebate. But I suspect that Medicare might actually see the value of having a rebate for patients within metropolitan. Why should patients within metropolitan Melbourne not be able to get access to that? Because it might take them half an hour to get to the doctor's rooms and have to take half a day off work, which is not all that different to some people just in the regional areas.
Yeah, I'll echo what Barton said there. But I suppose it's all about convenience, isn't it, really? That, some people are just too busy to come into the doctor. There's the parking situation, there's the parking fines. There's all those factors. What people tell me about, Cogra, for example. it's so good I got to speak to you like this because I didn't have to drive in or try to find parking. So there's a huge convenience factor. And like you said, the people that just need a sleep study result or some other simple result that you could discuss by video. The issue will be, will the government want to pay for it? Because I can see many of my patients in my area, if there's no rebate, they're, even though you might be charging a gap, that's all you charge them with no rebate. They still didn't want it. So it'll depend on the patient and where you're practicing, I think. I'm not sure with the budget. Hope Mr. Hunt is listening tonight, but how much money is in the budget for allowing that? But it'd be really a welcome extra optional way of managing patients.
What apps can you recommend for patients to monitor the condition that they can upload to their physician?
I haven't used any. Greg, do you have?
No, I haven't used any either. That's probably my next task, to look up mobile apps for, peak flows and things like that. There are self-monitoring spirometers that, like for single patient spirometers that they can purchase if you need repeat spirometries done over time that have apps linked. But I can't say I've used any. I haven't had time to look at that. I've been too busy trying to get this whole thing to work. But down the track, I can see that's something that I would definitely look at if I could get them to do peak flow monitoring, in those people that find peak flows of use, or maybe spirometry in some of those patients where you can access through an app their results from a remote location. That can be a huge
When it looked like in March or April, when it looked like COVID might actually take over our health system, I came up with the idea that for my regional patients in Gippsland, I might put together a COVID pack, which would have an oximeter, a thermometer, and a bit of education and a sheet where patients could record their saturations and their temperature. And this, I thought, would be useful for patients who were COVID positive but not sick enough to need to be in hospital. And so then I could provide, with the help of my team, we could provide a daily telehealth consult. So essentially they would be a little bit like a virtual hospital and just monitor them daily. And so if we had an idea of their oxygen saturations, their temperature, and saw them clinically, even though it was via video conference every day, it would give them confidence that they didn't need to be in hospital, and we'd also be able to pick up whether they're going to deteriorate around that day 4 or 5 and actually need to go to hospital. So I think that, doing things with technology has really fantastic ability. And I think that with this sudden change to telehealth recently, people will continue to look at ideas like this. And as Greg said, spirometry is, a fantastic one that we could monitor patients with as well.
Other than yourselves, where is the best place to find practical resources, such as the software and hardware and process you have described?
Well, I think there's quite a lot of information out there. A lot of the information in the journals is about patient care. With regards to the actual software, it's a bit hard, I guess. I think that having trialled quite a few different software packages and things, that the ones that I used, I think I would recommend highly. I think that the program that Greg's using for video conferencing is excellent, and it's probably a little bit easier to use than Zoom. The problem with Zoom is that it takes that you do need to download something. That's the major drawback I think that it has. But it is more expensive. And so Zoom's I find, more cost effective.
Yeah. Well, actually, you can get a discount at the moment.
Do you sell it?
There's a little bit of a discount at the moment. No. I've got nothing to do with you. But I think I joined up for a bit, and they placed me and offered a 30% off for 3 months. So it's a good way of trying it. I think a lot of allied health professionals have been using it for years. I like the concept of the waiting room with music. It's a bit more professional than just them waiting for someone to appear. And you can link in the billing, like you said, where they can even pay. We're not that sophisticated, but it's been easy to use. Yeah, definitely. In terms of resources, I'm definitely not a resource. I'm someone who's just struggled with it. But people like Barton who've done it for years, I think, are great resources. There is a course you can do through Charles Sturt University. It's a free course that I spent all of the Easter break doing. It was amazing. it's an online course on telehealth, and you will drown in resources. That's all I can say. There are I did a webinar a month or two ago and discovered there's actually an Australian professor of telehealth in Queensland. So Queensland and WA seem to be the leaders in telehealth. They've done it for years. They manage emergency departments remotely on telehealth. So if you want to find resources, there are places you can start. The Australian Telehealth Society, you can join it. The ACRRM, they all have resources on their websites, as well as the College of Physicians, and Medicare online have explanations about telehealth as well. So there's actually a bucket load of things out there. You just need to look for it.
Do you think you end up doing more investigations as a result of using telehealth that you wouldn't have done if you had been able to examine the chest?
I don't think so. I don't think so. I think that we rely pretty heavily these days on lung function testing, imaging, and the sleep studies and the tests and investigations that we have. I don't think that I would do more tests for patients via telehealth. It's a good question, though, and I guess I'd be interested to see if Greg felt that he managed patients any differently or investigated differently.
No, I don't think it's increased the number of tests done. I mean, teach the medical students that 90% of diagnoses are made on history. And so I think about how many times has examination changed my management. So it probably has prolonged things a little bit, whereas I haven't got the spirometry all in one day. I've sent them for a spirometry, and then we'll do maybe a phone consult after just to check on the results. You know, if this is a simple check on result or a video consult. So that's the only extra thing, is maybe it's created an extra consult, an extra step. But the number of tests really haven't
I think
increased.
that's exactly that situation where if somebody is complicated and you think that examination findings are going to be very important, say to differentiate respiratory from a cardiac cause of breathlessness, then rather than just sending out for tests that you wouldn't otherwise normally organise, you'd organise the tests that you'd normally organise, but then organise to see that patient face-to-face so that you can actually examine them properly.
Does anybody else have any questions? Well, it appears that was the end of the questions. Thank you, Dr. Barton Jennings and Dr. Glenn Kotsalatos, for your presentations this evening. I hope everyone has found this educational valuable. We would appreciate if you could now appearing on your screen. Thank you and good night.